Hello there, welcome back to Mastering Anesthesia. Let me ask you, what comes to your mind when we say ketamine, hallucinations, emergence phenomena, delirium? That is the reputation ketamine is infamous for. But to an anesthetist, ketamine offers haemodynamic stability, bronchodilation, analgesia, and sometimes the safest induction drug you have. So today, let's talk about ketamine. Are you ready? Let's go.
So, let us get to know a little bit about ketamine. We'll start off with the structure-activity relationship. This is what makes ketamine, ketamine. So, what is ketamine? It is a phencyclidine derivative. On the left, you can see its structure of ketamine, and on the right, this is the structure of phencyclidine. What that means is that phencyclidine is the parent compound from where ketamine is derived. So, what makes up the structure of ketamine? So it has a phenyl ring, a cyclohexane ring, a ketone group made up of double bond O, a secondary amine, and a chlorine substituent. Ketamine comes from the name of keto group combined with a secondary amine, so ketamine. Phencyclidine, on the other hand, is an anesthetic drug used in veterinary medicine. It is also a drug of abuse. It comprises of phenyl ring, a cyclohexane ring, a tertiary amine. Notice that it is lacking of ketone group, hence making it more lipophilic, and it is 10 times more potent than ketamine. Now that we've seen the structure of ketamine, let's now talk about its presentation. It is prepared as a clear colorless solution. You can find two preparations, whether it is in racemic mixture or as a single enantiomer pure preparation. Racemic mixture is a mixture of equal amount of enantiomers, whereas an enantiomer pure preparation is a preparation where you only have one enantiomer in the solution. There is a video about isomers that I have done earlier. You can check the link in the YouTube description below. Have a look to understand further about isomers. So racemic mixture of ketamine has both R enantiomer and S enantiomer, whereas single enantiomer of ketamine usually is prepared as S-ketamine. The enantiomer pure preparation of S-ketamine is 3 times more potent than the counterpart of R-ketamine. It is better in its side effect profile and is better tolerated in patients. It is water soluble, hence no pain on injection. The solution is acidic, having a pH range of 3.5 to 5.5. It has multiple concentration prepared in 10 milligrams per ml, 50 milligrams per ml, as well as 100 milligrams per ml. As for its routes of administration, ketamine can be administered via IV, intramuscular, oral, nasal, subcutaneous, rectal, intrathecal, as well as epidural. There are many uses of ketamine. Practical relevance to anesthesia includes induction, analgesia, as well as sedation. The dose varies according to the uses of ketamine. For induction, via IV is 1 to 2 milligrams per kilogram. Intramuscularly, some books quote 3 to 5 milligrams per kilo, and some books quote as high as 5 to 10 milligrams per kilo. Analgesia can be attained by giving subanesthetic dose of ketamine ranging from 0.2 to 0.5 milligrams per kilogram. As for sedation, intravenous infusion of ketamine at a concentration of 2.5 to 15 micrograms per kilogram per minute will give its sedative effect. Now going into the more interesting bit, how ketamine does its numerous effects. So number 1, its effects on NMDA receptors, or N-methyl D-aspartate receptor. It is a non-competitive antagonist of NMDA receptors. It prevents glutamate from attaching to NMDA receptors, glutamate being an excitatory neurotransmitter in the central nervous system, so glutamate is prohibited from exerting its effects on NMDA receptors. So when ketamine binds to NMDA receptors, it prevents glutamate from allowing sodium and calcium to enter the cell membrane. So this causes the states of amnesia, analgesia, as well as dissociative anesthetic effect. A little bit of extra pearl knowing about what dissociates actually mean by dissociative anesthesia. It means that the thalamus is disconnected from the limbic cortex. Thalamus being a place where sensory impulses are relayed, and limbic cortex is where awareness of the sensation. So what happens when both of these structures are disconnected? This causes dissociative anesthesia, where a patient appears to be conscious, but they are unable to process or respond to the sensory inputs given, such as patient has its eyes open but are unable to respond or feel any impulses. And number two, ketamine has also its effects on opioid receptors. They are weak agonists at mu, kappa, and delta, or MOD, COP, and TOP receptors. What it does is enhances opioid effects and reverses opioid tolerance. Number three, ketamine has also some effects on monoaminergic systems. What it does is that inhibits the reuptake of monoamines, so increasing their concentrations in synapses. This includes dopamine, serotonin, and noradrenaline. So when dopamine levels rise, you can see psychotomimetic effects as well as hallucinations. Meanwhile, the increased concentration of serotonin and noradrenaline causes its antidepressant effects on the patient as well as a CVS stimulant, increasing blood pressure, heart rate, as well as MAP. Next, ketamine also has effects on cholinergic receptors, including muscarinic and neuronal nicotinic acetylcholine receptors. It stimulates muscarinic receptors, causing tachycardia, bronchodilation, and increase in secretion. Conversely, it inhibits the neuronal nicotinic acetylcholine receptors, believed to contribute to its antidepressant and analgesic effect. And number five, ketamine also inhibits voltage-gated sodium channels. So what it does, it contributes to ketamine's mild local anesthetic-like properties. Now, as to the pharmacokinetics of ketamine, its absorption, distribution, metabolism, and excretion. As for its absorption, ketamine is relatively well absorbed orally, with an oral bioavailability of 20%, and it's also highly absorbed in its intramuscular route with 93% bioavailability. As for its distribution, following its administration via IV route, ketamine has bi-exponential fall in its concentration. First fall of its concentration is due to its redistribution across lipid membranes. Ketamine is extremely lipophilic. And next fall in concentration is due to slower hepatic metabolism. Ketamine is the least protein bound at about only 25% compared to the other IV induction agents. Ketamine has a high volume of distribution of about 3 liters per kilogram owing to its high lipid solubility and elimination half-life of 2.5 hours owing to its high hepatic clearance. Important points that we do not want to miss out when we're talking about ketamine is that it is a weak base, the pKa of 7.5. Its onset is 1 minute in IV induction, 5 minutes in IM induction, and its rapid onset is due to its extremely lipid solubility and owing to its effect on the central nervous system where it increases cerebral blood flow. As for its metabolism, ketamine is extensively metabolized by hepatic microsomal enzymes. It has a high hepatic clearance of 1 liters per minute, making its elimination half-life of 2 to 3 hours. Ketamine is demethylated by hepatic P450 enzyme system to produce norketamine. Norketamine has 30% potency of its parent compound ketamine. Therefore, it is an active metabolite. Norketamine is then conjugated into inactive metabolites, where these inactive metabolites will be excreted through the urine. Okay then, now let's talk about ketamine's pharmacodynamics. Number one, what does it do to the heart? This is very, very important. It's cardiovascular system's effect. Ketamine is preferred and popular in its use in acute shock patients. Why? Because it increases arterial blood pressure, it increases heart rate, and increases cardiac output. And notice the emphasis on acute shock patients. This does not apply to a severe late-stage shock. However, it also increases pulmonary artery pressure and increases myocardial work, increasing its consumption of oxygen, and these are not so desirable effects of ketamine, so it has to be used cautiously in patients with heart conditions and ischemic heart disease. All of these cardiovascular effects can be observed due to its indirect and direct myocardial effect. The cardiovascular system stimulatory effect comes from its indirect action via its central stimulatory effect of the sympathetic nervous system, as well as the inhibition of reuptake of norepinephrine, making norepinephrine abundant in the synapses. So these combined will cause the increment that we've mentioned before, the increased arterial pressure, heart rate, cardiac output. However, ketamine is a double-edged sword where it also acts as a direct myocardial depression via its action of inhibition of L-type voltage-gated calcium channels. So keep in mind when you're using ketamine that it has both stimulatory and depressant effects. So be careful when you're using on patients with sympathetic blockade, such as those that you've given spinal anesthesia, and also those with exhaustion of catecholamines, such as patients in late stage of shock, where its norepinephrine has already been depleted. In these cases, there won't be indirect stimulatory effect. What predominates is only its direct myocardial depression. So instead of the CVS being stimulated, the CVS system will collapse with the administration of ketamine in this special group of patients. Number two, ketamine's effect on the respiratory system. It increases respiratory rate, it preserves laryngeal reflexes, it maintains the patency of airway, relatively, but with caution, increase the muscle tone of the jaw, possibly causing airway obstruction. It also causes bronchodilation, great for patients with asthma, and it increases airway secretion, which can be attenuated by administrating glycopyrrolate. As for its effect on the central nervous system, ketamine causes dissociative anesthesia, like mentioned before, seen on EEG as a dissociation between thalamocortical and limbic system. Next, ketamine, part of its desired effects include intense analgesia and amnesia. Vivid, unpleasant dreams are also part of its effect, as well as hallucinations and delirium. These are part of emergence phenomenon seen in ketamine, where it can be reduced or attenuated by the concurrent administration of opioid or benzodiazepine. Very important changes in central nervous system is it increases cerebral blood flow, oxygen consumption, and intracranial pressure. It also causes increased in muscle tone, including some jerky movements of the limbs. In gastrointestinal tract, ketamine can cause increase in incidence of nausea and vomiting. It also increases salivation. And lastly, renal effect of ketamine. In non-prescription high-dose administration of ketamine can cause severe interstitial cystitis that may require cystectomy. Thank you so much for watching the entire length of my video. I hope you like it. Please comment, like, and subscribe. See you in my next video.
Thank you for watching. If you find these videos helpful, please hit the like and subscribe button to show your support. Comment down below what topic you want us to cover next. Till next time, see you in the next video.